Good morning and welcome, everybody. On behalf of the Black Midwifery Collective and Health and Medicine Policy Research Group, we are so excited that you are here joining us for the final event in our four-part Illinois Community-Based Birth Justice Strategic Plan launch series. My name is Anna Yankelev, and I am still your host. I'm the Director of Strategic Workforce Initiatives at Health and Medicine, and I've been working closely with the Black Midwifery Collective to facilitate the strategic planning process and develop the plan itself. Over the past year and a half, dozens of community-based birth workers have supported the development of a new plan that elevates community-based birth justice. We've diligently researched the factors that contribute to poor perinatal health outcomes and explored ample data about the life-saving impact community-based approaches have for so many. Our first three sessions explored findings from several research projects about the barriers and opportunities we face in making our vision a reality. Several shared themes emerged from those findings, and we'll hear more about those today, but we know that we have a long way to go. The Illinois Community-Based Birth Justice Strategic Plan is a roadmap and a call to action to help build a new reality in which every birthing person, regardless of their race, ethnicity, age, immigration or insurance status, geography, or health, has access to the community-based resources and opportunities they need to have a safe and positive perinatal and birth experience. We are honored and excited to share this plan with you all. After we go through some housekeeping, we will review some key terms and provide a brief introduction to birth justice and why this work is so critical at this moment in time. Then we will bring back our speakers from the first three sessions for a panel discussion about the shared themes and recommendations from their research. Then Nora and I will walk you through the plan itself, where to learn more, and how to get involved. And we hope to have some time at the end for a Q&A. Some quick housekeeping notes. Please introduce yourself in the chat if you haven't done so already. We are recording and translating this webinar, and all of our recordings will be available on our YouTube channel. And please be sure to post any questions you have in the Q&A section and not in the chat. Quick review of some key terms so that we are all working from the same definitions. When we say perinatal, we're referring to the time period from when someone becomes pregnant to a year after giving birth. Birth justice includes the right to choose whether or not to carry a pregnancy, the right to choose when, where, how, and with whom to birth, and the right to breastfeeding support. And we, of course, credit Jamara Amani and the Southern Birth Justice Network for this definition. And to make sure we are all on the same page about what we mean when we talk about community-based birth workers and settings, we take a rather comprehensive view that includes settings such as birth centers, FQHCs, health departments, community organizations, and people's home, among others, and workers, including behavioral health workers, midwives, doulas, community health workers, lactation counselors, home visitors, and others. Before we go any further, I want to welcome Star August Ali, aka Sister Star, founder and executive director of the Black Midwifery Collective, and the visionary and leader who inspired this plan, to share some opening remarks.
Great. Thank you so much, Anna. Thank you, everybody, for joining us again for another session. I appreciate all of your time, and we appreciate all of the efforts that you guys are all putting forward in your respective spaces in regards to birth justice in the state of Illinois. Let me start off by saying I come to this work not only as a midwife, but also as an advocate, also as a Black mom of 4 whose life has been shaped by the very systems we are working to transform. I personally have sat in rooms carrying questions I was afraid to ask. I felt the weight of being unheard. I have watched loved ones struggle to receive respectful, compassionate care. I know what it means to hold both deep intuition and deep concern, because too often our healthcare systems ignore, devalues, and endangers Black bodies. But I also carry something powerful, and that's legacy. I'm a descendant of a grand midwife who practiced in the 1940s. From her, I inherited a tradition rooted in ancestral knowledge, trust, and community-based care. That lineage guided me as I trained to become a certified professional midwife. For over 3 years, I practiced underground illegally in Illinois to ensure Black families could access culturally congruent, safe maternity health care. I did that work because our communities deserve options. They deserve dignity. They deserve care that honored who they are. Through my work as a midwife, policy advocate, and systems change strategist, I have seen clearly where the barriers live. I have testified before the Illinois General Assembly. I have navigated regulations that marginalize community-based providers. I have fought to ensure Black midwives and families we serve have a voice in decisions that shape our lives. And here's what I know. Black communities are not failing our families. Systems are. That is why the Illinois Community-Based Birth Justice State Strategic Plan matters right now. For too long, community-based providers have delivered life-saving, relationship-centered care while being excluded from the very policy and funding decisions that determine our sustainability. This plan changes that. It establishes a statewide framework defined by community-based providers themselves. It prioritizes real strategies, identifies opportunities to scale what works, and names who will lead implementation, and outlines resources required to make real change. Built by community and for community. This plan centers equity, culture, and lived experience. It lifts voices from Chicago to rural counties, from seasoned leaders to emerging practitioners. Community voice here is not symbolic, it is foundational. And why now? Because Illinois is at a turning point. There is a growing political will. There are supportive elected officials. There is increasing recognition that community-based innovation is essential to addressing perinatal inequities. But momentum without coordination and without community leadership can reproduce the very inequities we seek all of us to dismantle. The first and only community-based state strategic plan in the state of Illinois. This plan offers a unifying community-defined roadmap. It aligns lived experience with system-level opportunity. It gives policymakers, funders, and institutional partners a clear framework rooted in equity, accountability, and shared power. Because the seat of the table is not about recognition. It's about power, the power to define care, the power to name our needs, the power to demand systems that support life, dignity, and autonomy. This plan is an invitation to participate, to be counted, and to be heard. Together, we are not asking for a seat. We are building the table for birth justice in Illinois. I thank you all so much, and I will pass it on to Anna.
Thank you so much, Star, for your leadership and inspiration and wise words as always.
Thank you.
So why do we need this plan? Illinois has a big problem. Not every birthing person has the same opportunity for a safe and healthy birth experience, leading to preventable serious injuries and death that impact some communities more than others. Avoidable and unfair differences in health outcomes like these are known as health inequities. We believe that we need to advance birth justice in order to eliminate these health inequities. So who is more likely to experience pregnancy-related health inequities? Black women are more than twice as likely as white women to die from a pregnancy-related cause, and in Chicago, that number jumps up to 6.5 times as likely. Black women are also more than twice as likely to have a potentially life-threatening condition or complication during labor and delivery when compared to white women, and women on Medicaid are over 3 times more likely to die from a pregnancy-related cause than women with private insurance. And this is particularly important because 40% of all births in Illinois are covered by Medicaid. Older women, as well as women with a high school education or less, are also more likely to die from a pregnancy-related cause when compared to their counterparts. And while recent data have shown improvements to mortality rates for birthing people overall, it's important to note that rates for Black birthing people in particular have remained unchanged, or in some cases have even worsened. Notably, 1 in 3 deaths occur during pregnancy and 1 in 3 occur more than 60 days postpartum, meaning that the majority of maternal deaths are not occurring during labor and delivery. And importantly and horrifically, 9 in 10 deaths are considered preventable. And this statistic right here is ultimately what we are trying to change. Our strategic plan explores what we can do to help eliminate these preventable deaths and promote the health and vitality of all birthing people. But we need to understand what causes these inequities in order to effectively combat them. For many people, especially those from communities of color, immigrant communities, rural communities, and others, accessing comprehensive perinatal care in health and hospital systems can be difficult or even dangerous because not everybody can get the care they need, either because they live in a perinatal care desert, like residents of 1 in 3 Illinois counties do, or because they can't afford the care they need. There also simply aren't enough workers to meet the demand, either in clinical or in community settings. If we relied exclusively on OBs for delivery, we would need 40 to 50% more of them to ensure access to care and reduce physician burnout. And we don't have enough community-based providers either. Right now in Illinois, there are less than 40 registered CPMs, certified professional midwives, and only 5 of them are people of color. And we would need over 1,500 more doulas to support every Medicaid-covered birth. Our third session explored this in much greater detail, but racism and discrimination prevent many people from seeking or receiving care, and many women report experiences of dismissal, discrimination, and disrespect due to their race, insurance status, immigration status, age, or substance abuse. Many birthing people also have physical and mental health needs that require care and support outside the delivery room. For example, substance use disorder is the leading cause of pregnancy-related death in Illinois. Access to healthcare, safe housing, healthy food, reliable transportation, living wages, childcare, and other factors known as the social determinants of health also influence maternal health outcomes. And birthing people who have unmet social determinants of health also often struggle with chronic physical and mental health issues, including substance use disorder. And because of that, many people need to navigate multiple barriers to get the care they need, and often these barriers impact and compound upon one another. Additionally, expected hospital closures, cuts to Medicaid and mental health services, and other resources are only going to worsen these issues. The resulting inaccessible and unsupportive perinatal systems cannot be improved with simple fixes, so we must explore how alternative systems and approaches like community-based birth resources and supports can help. I'm going to talk through some key points about this, but you can check out the strategic plan for a lot more data and information. But the fact is that the majority of births are low risk and can safely be managed by midwives or in community settings. And more people are looking to give birth outside of hospitals, especially Black and Latina parents. Fortunately, the data overwhelmingly show that the right community-based birth resources and supports can help advance birth justice and improve health outcomes. First and foremost, community-based birth resources can help reduce pregnancy-related morbidity and mortality significantly. Individuals who receive doula or midwifery care and support before, during, and after birth in hospitals or birth centers have lower rates of cesarean sections, preterm deliveries, low birth weight babies, and stress and anxiety levels, and higher rates of breastfeeding and perinatal care, with one study finding that Medicaid patients with doula support were half as likely to have a C-section and had a 60% decrease in rates of postpartum depression and anxiety when compared to those without doula support. Additionally, the unique and trusting relationships forged between birthing people and their community birth supports can also help birthing people adopt healthier lifestyles, reduce stress, and improve attendance to perinatal health appointments. Doulas in particular have been found to serve as an effective advocate and buffer for birthing people of color navigating experiences of racism or discrimination in health systems. Community-based birth resources and supports can also help reduce barriers to care because they are by nature based in the communities that they serve and have the ability to meet patients where they are, which helps ensure compliance to care plans to those with access barriers. This is particularly important for mitigating those 2 in 3 maternal deaths that happen outside of labor and delivery. Also, it's much faster to build up the community-based birth workforce, and our communities need help now. Training for this workforce takes months to a few years versus the decade or so it takes to graduate nurses and doctors. And because these programs are shorter, they're also much cheaper, making them a more viable option for individuals without family resources to afford tuition. Community-based birth resources also save money for insurance providers, health providers, and birthing peoples themselves. Home births and birth center births are significantly less expensive than hospital births, and the recent addition of doula, lactation counselor, birth center, and midwifery services to Illinois' Medicaid benefits will make them even more affordable. And because midwife and doula-led births often have lower levels of medical intervention when compared to obstetrician-led births, they're significantly less expensive even in hospital settings. Again, you can find a lot more data and information about this in the strategic plan itself, but the data don't lie. Community-based birth resources lead to improved health outcomes, reduced barriers to care, and lower costs for birthing people and providers. Next, we will hear from the researchers featured in the first 3 sessions to learn more about the barriers preventing us from ensuring that every birthing person in Illinois has access to the community-based birth resources and supports that they need and deserve. We need to understand these barriers so that we can build effective strategies to overcome them. I am delighted to bring back Chastity Mays, Camille Williamson, Star August Ali, Carrie Stewart, and Kiari Kershaw, who will be representing the data that Nicolette presented on last week for this conversation. I'm not going to reread each of their very impressive bios, but you can check out birthjusticeillinois.org/events for recordings of each of their sessions and their bios. I'm also delighted to welcome Maykazen Alexander to moderate this panel. Maykazen Alexander has been dedicated to enhancing the quality of life for Chicago residents by providing equitable services, particularly in housing, healthcare, economic stability, and inclusion for over 2 decades. A recognized visionary, Maykazen has worked with individuals of all ages from conception to adulthood. As the founder and executive director of Nia Incorporated, she brings extensive experience as one of Chicago's first traditional spiritual midwives. Her expertise includes being a perinatal educator, doula, and motivational speaker, and she holds certifications in infant massage, childbirth education, full spectrum doula, prenatal and postpartum yoga, breastfeeding, and nutritional counseling. Maykazen, take it away.
Thank you, Anna. I appreciate that. And thank you all for joining us today for the final presentation of this series. I see some familiar names pop up in the chat, and I know that many of you have been with us throughout this series. So thank you for staying with us. I also want to thank those of you that participated in this work by responding to the surveys, participating in the focus groups, and sharing the information with your networks to also participate. So over the past 2 years, these wonderful, skilled, talented researchers conducted surveys, focus groups, and key informant interviews with community-based birth workers, people that serve to better understand their barriers, needs, and priorities. And these studies shared several common themes related to the growth and sustainability of community birth options. Our panel today will discuss these themes and our researchers' recommendations for how to overcome them. And I think what really resonates with me is that we are finding viable solutions to what we've actually found in the research. And so one of the first themes I'd like to speak to our panelists about is racism and discrimination, how it hurts birthing people and community birth workers alike. I think that what really resonated with me in some of the research that was identified is over half, 45% of doulas and almost 89% of CPMs have experienced discrimination in healthcare settings. And what also resonated with me is that over or more than a quarter, 28% of community-based birth justice workers reported that witnessing racism at work made it more difficult to carry out their work. And so my question today to our first data panelist is, Star and Carrie, is based on what you've learned, what aspect or element of the strategic plan are you most excited for? And what, let me rephrase that. Scratch that question. What did your research find about this theme, and what are your recommendations for overcoming this barrier?
I can go first. So I think you already alluded to it. We found that a lot of the Black birthing people we talked to felt that they weren't listened to, or they had potentially been offered services or denied services and resources that could have been helpful to them, because they were viewed as not being willing to travel for them or things like that, feeling pressured to take certain treatments, like going right on birth control after giving birth. And many felt like having racially concordant providers or would help them. And I think So one of the things that we thought would be a good recommendation is investing in a more diverse workforce, trained to provide culturally and structurally competent care, but also making people more aware of community-based birthing options and having resources or a way to understand if you do need to or want to be in the health system, who would be a supportive provider. So really increasing that awareness of the opportunities that are available to have a safer, more healthy birth.
Dar, would you like to chime in? And thank you, Kiari.
Yeah, based on what we were seeing within our birth worker focus groups, a lot of us that are currently birth workers right now on the front lines doing the work in the city of Chicago, in Illinois, a lot of us have worked within a hospital system and have decided to actually move into a community-based setting, but based on what we were actually seeing, what we were hearing, what we were witnessing with our own two eyes. I know that you and I, Megazin, as midwives, have have our notion that we talk about a lot about really like not wanting to attend births within a community-based setting because we're always constantly having to be on guard in defense of our clients in regards to advocating their needs. You know, I mean, just thinking about like delayed cord cutting, for example, right? Like we know that there's a lot of benefits in regards to a tremendous amount of the blood volume coming through after the baby has been born, a lot of benefits. But yet, you know, there's a quick a desire essentially to cut the cord as soon as possible, even though it may be denoted or noted within their birth plan. We still have to stand on guard to be able to defend people's needs and desires for their birth in a setting where they're paying to have services there, which is ironic. So I think because a lot of us have witnessed it, a lot of us have decided to move within a community-based setting. And I think from the data that we've seen and all the information that just came out, there's a huge desire primarily from communities of color to have birth within a community-based setting. I know that I mentioned, I think earlier in the last call, when I first got to Chicago, because I'm originally from Illinois, I held like a round table within my own house, in my own living room. There was about 10 to 15 women of color that we were all just talking about our birth experiences. And one key theme that resonated that came out was like this deep fear about going into a hospital system, a fear that they would not either make it out alive or our babies wouldn't make it out alive. And this is not just some random notion that we had. This is based on lived experience. This is based on other people that we have within our circle that is experiencing the same thing. So as we have seen post-COVID, a huge rise in unassisted home births that have not been documented and allotted for in regards to the data that's coming out from what do you call it, the registrar's office in the state of Illinois. There has been a huge uptick in regards to people wanting a community-based birth. And then this data also, like I said, not being captured in regards to births that are being identified as unassisted free births within a community-based setting. So yeah, I think obviously, you know, I think that it's quite clear this isn't very difficult to figure out, right? We have a huge system that has a lot of inequities. Like I mentioned earlier, racism is not going to be eradicated within our lifetime. We need to just all be real about that. People are not wanting to go into the hospital. We have horrific data that's coming out in regards to obstetric racism, obstetric violence. It's concordant with what's happening across the country. People are wanting community-based births. We need to be investing our resources to grow and diversify the midwifery working force to meet the demand that's now coming out for a community-based setting. And I'm excited to have everybody here to talk about it. So yeah, I'll pass it on. I mean, I don't think there's really too much to really sit here and us delve about it. Like the solution is quite obvious, right? Like it's quite obvious. But yeah, we can go through the technicalities to have a conversation about it. But I mean, all of us are pretty bright. We understand what's going on. The solution is quite obvious.
Thank you for that, Star. And what really is powerful is that we are looking at lived experiences. This is not coming out of a vacuum. We have people who are responding and have been responding for quite some time. And just think that 42%, and like Anna said, the data is on the website, but 42% of community-based birth justice workers identified that secondary trauma that they felt stemming from their own clients made it difficult for them to do the work. And so today we are, finding solutions to make that happen, to change that dynamic to a more positive setting. So thank you both. I appreciate you chiming in. We'll move now to our next theme, which was the current workforce does not have the size, support, or geographic and racial presentation to sustainability meet the state's needs. And so I am going to speak with our next presenters, Camille and Chastity, who have drilled down on some of this work. And I'd like to just highlight a couple things that came out of that. In 2025, there were only 4 licensed CPMs of color in the entire state. That's glaring. And as of 2025, there are only 5 birth centers operating in Illinois in order to ensure that there is at least 1 birth center in each of the 40 obstetrical planning areas in Illinois. We would need an additional 35 birth centers. And finally, I'd like to just highlight that doulas and CPMs need living wages, childcare assistance, and other social and emotional supports to avoid burnout and to sustain their work. And so welcome, Camille and Chastity. I'd like to pitch the same question to you, which is, what did your research find about this theme, and what are your recommendations for overcoming this barrier?
Would you like me to start?
Yes, Camille, I'm pitching it to you. Thank you.
Thanks so much, May Cousin. And I just want to say thanks so much, Dar, for your opening remarks. I, as a person who is very passionate about maternal child health for personal reasons, not just professional, I was really excited to have all of the dialogue that I had with doulas and CPMs, not just from a research perspective, but really in a deeper immersion into the full spectrum of all the different types of supports that people can have when they are becoming a birthing person and ultimately will give birth. A couple of things that I will say that I think are glaring from the research that I was able to attain is, one, the community-based birth worker workforce really is passionate and moves from a very soulful place to do this work. I describe it as heart work. And that being said, when we got to questions specifically about compensation and livelihood, the compensation does not match the full breadth of work that community-based birth workers are doing. I just want to give a couple of examples that I heard repetitively in focus groups and key informant interviews. A lot of community-based birth workers are not compensated for being on call. And as anybody who is providing any kind of support for a birthing person knows, being on call could be minutes, could be hours, could be days. And your life is still lifing as the support person for the birthing person. And many of the people that I interviewed or had focus groups with had other life responsibilities, including other jobs to supplement their income, their own children to take care of that range in ages from infants to teenagers, and also other dependents in their families that they might be responsible for, such as aging parents. And so what I found was that a lot of community-based birth workers were holding quite a bit, not just the birthing people that they're there to support, but their own lives, and trying to do so on very limited income and very limited resources, while also still trying to gain more understanding of additional resources that are necessary for clients that might fit within a vulnerable population, such as somebody experiencing domestic violence, somebody who is an immigrant, someone who does not speak English, someone who is disabled, someone who is not an adult, but a birthing person, someone who is having challenges with substance use. So they're holding a lot, wearing a lot of hats personally and professionally while doing this hard work. And my greatest concern is not only do we not have enough of them, but once we start talking about how to further expand this workforce, how are we going to make sure that we are supporting them to be able to continue to do the great work that they need? And they need a livable wage. They need health care insurance for themselves. They need childcare support. They need to be compensated for every aspect of work that they do. And they provide quite a bit of services, but also support isn't necessarily just what is documented on a log sheet. It is that on-call time. It's the birthday that they don't get to have or celebrate with their child. It's the holiday they don't get to have with their families. It's the not being able to be there for someone in their family so that they can be there for someone who is actually preparing to birth. So I think it's important to highlight all of those very comprehensive human aspects of what community-based birth workers are holding, so that as we move forward with integration plans, as we move forward with continued talks about compensation, that we are consistently aware of how to make sure we are being fair, equitable, and responsive in a way that helps, that ultimately will sustain how Illinois will continue to make this pivot.
Thank you, Camille. I really appreciate it. Chastity, you want to chime in?
Yeah, so thank you so much. And I mean, I would just add that I'm always going to point out that I'm really grateful to Star and everyone who was part of this plan for including me and Southern Illinois, because we are here and we're doing the work. I think two of the things that stood out to me about our research was that we really did need to do a scan of all the birth workers in Southern Illinois to see who is here and who's doing what. But in doing this scan, it shows that we do have several providers who will be leaving the field. So that means that we need to recruit, train, and build our own workforce. I think especially in Southern Illinois, we find that it's important to grow our own. And that is across the board in whatever profession that you have. But my passion is in birth work. So we need to grow our own midwives. We need to grow our own doulas. We need to grow our own lactation professionals. So I really think that's just so important. I'm actually so excited that Carrie is now coming to Southern Illinois through Choices and providing family planning to our area. I mean, I could just scream. I'm so excited about that. That is an option for us. Part of this plan, we find that choice and clinical need is not always it doesn't always bring like where you go. In Southern Illinois, we only have so many choices. We're very limited in where we can go for providers and labor, and even in the home birth space. Our choices are so limited. We are a maternity desert, a true maternity desert. So I know that Carrie coming down is bringing us more choice of who we can choose to be a provider. It's giving us more choice of who can deliver our babies. So I think that the scan for Southern Illinois was just so important to show us where we are, what we need to do, and we are providing solutions. We have trained several doulas, the Little Resource Center and Choices. Those doulas are now practicing. Now we're going to move into trying to grow our own midwives. So I think this plan is so important, and the scan was important for Southern Illinois, just pointing out what we need to do for our area.
Thank you, Chastity. I appreciate that. And for the work we're doing in Southern Illinois. Woo woo. All right. And so our third theme was health and hospital systems and other community-based organizations don't always know how to promote or coordinate with community-based birth options. And I think that these two panelists can really, Carrie and Chiari can really drill down on this, but I've got to put this out here. One of the things that were found is that doulas and CPMs express challenges in knowing how to refer to and coordinate with social service providers serving their patients. And I can just say, I think Star touched on it. There are times when it was very, very threatening for me to be in those spaces for fear of being put out because I was advocating. And so I needed to know like who I could trust to even refer our patients to. And then the other piece I just want to mention is that over one third, 37% of community-based birth justice workers reported that a lack of integration into the medical system creates significant barriers for carrying out their work. So we're here, we want to work with you, but we're getting pushback all along the way. So Kiari, I'm going to pitch the same question to you, which is, what did your research find about this theme, and what are your recommendations for overcoming this barrier? Carrie, I'm going to put it to you first.
Good morning, everybody. I appreciate everyone on this panel and for everyone joining us today as we try to strategically come up with a plan. But I think what the research that I found in the things that we did specifically throughout the state is institutions that are providing this care don't know their neighbors being the other organizations and community workers in the community, and we're not being good stewards of that. And so I want to make sure that if we don't do anything, that we know who's doing this work in the community: hospital, home birth, birth center. And there needs to be this collaboration conversations consistently about who's being added to the table, who's doing this work, how we can work together. Because at the end of the day, it's collaborative. It cannot be one-off. We've done this silo work for so long, it's not helpful. We have too many individuals passing away for no reason. All of this stuff is preventable. And so when we talk about really coming together and provide a solution, that means every single individual who has a hand in maternal health care needs to be at the table or have a representative at that table. And so we just have to be intentional on that. And I think we're starting to do that, and we're providing the voices about their experiences, whether it be with the patients, whether it be with the providers, even the hospital, and providers have their thoughts about their experiences too. We need to hear all of that. And that's how we need to make this better. But we have to work together. We cannot do this separately. And so I want us to really be intentional about that, and going into our communities and introducing ourselves, learning about the community, having open houses, bring folks to your home, right? You're a new neighbor in the neighborhood. You should know what the labor and delivery unit looks like. You should know what we do. You should know our policies. You should know about the NICU. But we also want to know what you do. What does your organization provide? How can we work together? So we can't say, I don't know. That is unacceptable. Everybody should know who their neighbors are and who they're working with and who they can refer people to. And we don't need this competition about this work. We all have a hand in it. And if people want to have home birth, if people want to have birth center birth, if people want to have a hospital, that's the purpose of having options. Options make life last longer. This one thing for everybody does not fit, and we know this. And so that's pretty much the biggest thing that came out, is that people don't know about midwifery care. People, are uneducated about the things that we do. We're not out here rogue and, trying to have horrible outcomes. We want to work with the institution. We want to transfer individuals if they need that care. But we have to be received. Okay. And from both sides, we have to be received. And so we're starting those conversations. I want the entire state, whatever level you are, to be receptive to those conversations so that we can have better outcomes in Illinois. We have an opportunity to be an example for the rest of the United States of America for what it looks like for collaborative care across the board. And we can do this. We have the representatives in the state and the House that are supporting us. So if we don't do this now, we're losing the opportunity and the window to do this. And we're going to get it done.
I think I'm just going to be brief because that was fabulous. And I know we have other themes to get through, but just wanted to emphasize we had a lot of the same findings. And I think just this idea of whose job is it to meet the neighbors and really understand what other resources are available, because I think it's easy to say there's an outdated list, or I don't know, or this is somebody else's job, and it's the birthing people who suffer from that. So just trying to like emphasize that part. But yeah, that was well said. Thanks.
Thank you,
Ditto.
Carrie. I just want to amplify what you said. Thank you so much. You hit it right, the nail right on the head. I would like us right now to really look at there's a model that we can adopt, because Carrie's right. This is an opportunity for us right now. So smooth transitions in Washington State is a perfect example. We can implement that in this state so that there's intercollaboration on both sides to benefit our community. So I just encourage everybody to look into that particular model. We can do it here in Illinois as well.
Thank you so much. Thank you so much, Carrie and Kiari. Right on point. Well said. And we have to move along. Like Kiari said, we are almost close to our time, but we're going to get it in. If you hang in there with us, we will complete this in a tiny manner. So thank you both so much. That was fantastic. And so our last point that we'd like to bring out is the last thing: people don't know about community-based birth options or how to find the right resource to meet their needs. And I'm going to pitch this to Sister Star and Chastity. I am not going to go into more than two of what I found, but I do want to just say that many birthing people need support related to food, housing, transportation, and other determinants of health, but aren't sure how to find or access those resources. So, Star,
Yes.
Chastity, Star, you
Yes.
want to pitch in? Thank
Sure.
you.
I like to say, so one of the foundations of the midwifery model of care is it's a holistic model, right? So we're not just doing the physical aspect in terms of getting fetal heart tones, blood pressure, urinalysis, et cetera, et cetera. We're actually meeting people where they are, going to their homes, meeting their support system, their partner, their children, et cetera. Also doing an extensive plan in regards to their diet. So when you talk about food insecurity, we actually go to their houses. We sit at their table, we go in their kitchen, open their refrigerator, pull out the food in their refrigerator, sit with them, go through the ingredients, see where there might be deficiencies, and actually make recommendations based on food. So we're addressing the root of it. We're not waiting until it's the last minute when we now have to introduce pharmaceuticals to address an issue that really should have been addressed from the very beginning, right? And the work that we do, it not only impacts the birthing person, right? But you're setting up lifestyle changes that impact that family, that impact other families within the community, and it has a huge impact for multiple generations. So when you talk about work being siloed, I feel like midwives, we are the ones that really, specifically within a community-based setting, that meet that gap, because we are providers that live next to you, right, in your own community. We are a resource to you. So if you don't have any food, we're already connected. We know exactly where you can go and get food. Or if you need to get chiropractic care, we're already connected with the local chiropractor that can potentially offset some of the fees, because we know that you may not have the finances to be able to receive that type of care. So this is what we need. This is what our people need right now. We need to reduce this silence. We need people that are very conscious of the resources that are currently within our communities, right? Not outside of our communities, but within our own communities. That's what's going to strengthen us, not only from individual households, but as a community overall.
Thank you, Star. Thank you, Star. I appreciate that. Chastity?
I mean, I'll just add that to what Star said. Knowing the resources in your community is so important. I've had several homeless clients, and being able to reach out to personal connections we have at housing, being able to reach out to the food pantries, being able to do these things allows us. We've gotten several clients into housing while they were pregnant. So we are serving them while they're pregnant. Not only are we providing the prenatal care and the support they need on the birth work side, but we're also helping them get housing and food. So you're doing that wraparound care that's so needed for our communities and families. The approach that Carrie has brought already, and she's only been here, for like a month. She approaches this as a team. Every meeting I've been in with her, she says, myself and the doulas are a team. I want the doulas to come to their prenatal appointments with their clients. I want them to come to the postpartum appointments with their clients. Where Carrie is in a delivery, I myself am a doula, and maybe I'm over here with the client and we're at housing, helping them to get the housing they need. When I'm telling you that approach, we are not used to that as doulas. The midwife saying we're a team, we want you to work with us, because that care is what's going to get our families exactly what they need.
Thank you, Chastity. And it truly is all about the families that we serve across the state of Illinois, period. And I know, Anna, I know we are like 2 minutes past time, but I do want to go into current funding and reimbursement rates aren't enough to grow and sustain the workforce and community birth setting like birthing centers. We got to get this in. So I need everyone to just flow with us as we go into our final part. And with that, I'd like to hear from Camille and Carrie.
Dr. Williamson, you want to go ahead? I said what I had to say.
Sure.
But I'll add at the end a little bit about, I think, what we need to do. But go ahead, you go first.
Absolutely. So in my research, I did hear overwhelmingly from both doulas and CPMs that the current or proposed reimbursement rates are not fair or adequate to maintain a livable wage. And as I mentioned previously, regarding the workforce needing to grow, but also needs particular types of support, and the workforce needs to grow in a way in which we're making sure there's some racial concordance with birthing people who will be accessing their services and supports. That being said, we have to be willing to, I guess, there's a greater opportunity here to set an example for what a comprehensive healthcare model can look like with an integration where both hospital and health and traditional healthcare settings and community-based settings work in a way in which there's some parity, work in a way in which the focus is on the birthing person, work in a way in which not only are the physical needs of the birthing person being considered, but the social and the environmental needs are being considered. As I mentioned before, it's very difficult for community-based birthing people to be able to hold all that they're holding while not making a livable wage. And so I'm hopeful that in this move that Illinois is making with the birth equity blueprints, the upcoming discussions that we plan to have to talk about integration models, that we move in a way in which we're thinking critically about sustainability, and a livable wage is a part of that equation. So I'll stop there.
Thank you, Dr. Williamson. And I think in addition to that, as we have birth centers, we talk about the collaborative care, but we also need to, obviously talk to insurances about reimbursement in that appropriate amount for all the services that we provide, whether it be home birth, birth center, hospital. There needs to be equity in that. But we also, with the birth centers, specifically, and in collaboration with our partners that are, overseeing births at home, really need to look at our plan of services. What can we do collectively, but what in addition to birth that we can have at the birth center to sustain? Those of us who know who've been in birth, it is not sustainable just alone by itself. We have to have other services. So we're doing family planning in, Southern Illinois at Choices. We have other services that we provide because we know that right now in the climate that we're in, birth isn't paying us the way it should. So we have to be very strategic and smart about the other services that we provide in order to sustain the option that we truly need. Should we be doing all of that? We shouldn't, but we got to be smart. As Sar said, we know what we're doing. We know what the conversation needs to be had. We know what works and what doesn't work. And so we need to sit at the table and have that conversation as well. What other services are we providing? Are we bringing the doulas in? Are we bringing lactation in? Are we bringing physical therapy, pelvic floor? There's a lot of services that our communities don't have access to that we could put that in our collaborative model, that so we are sustaining all of the services for this. So we have an opportunity, again, I'll say, to be the shining star of all the things birth. And we just really need to sit down and do that.
Thank you, Carrie. And you're so right. We have all the things and funding to do these things And a great reimbursement rate will help us because we know we're stretched out and we do the work regardless. I want to thank all of our panelists this morning. The information, the work you've done is great. The work continues. The work is great work. Thank you so much. And from now, I will pass it on to Anna. But before I do, let me say, please put your questions in the QA chat. Thank you.
Thank you so much, panelists, and thank you again, May Cousin, for moderating. I'll also add that May Cousin has been working on creating a statewide coalition of doulas, and we'll be releasing a related strategic plan in May. So if you're a doula and want to get involved in that work, please reach out to May Cousin. I'm sure she'll drop her info in the chat. So now that we know why we need this plan and what barriers we need to overcome, Nora and I will walk us through how we created the plan and the plan itself. So Nora, you're up.
Thank you, Anna. Thank you, panel. It has been such a joy and an inspiration to work with each and every one of you during this process. You're amazing. And as I like to say, you rock. Okay. I'm gonna start with, can we go to the next slide? Sorry, I switched yeah. So I'm going to go through the plan, the process, and some people have heard some of this already, but for people who have never joined before, for transparency, we just wanted to let you know how this all evolved. At the core of the planning process was our statewide coordinating committee, and this group met monthly for over a year and advised on data collection and analysis, summit planning, implementation, strategic planning, and the contents of this report. This included drafting the mission, vision, and values and priorities for the plan. And it was composed of a cross-disciplinary group of community-based birth justice leaders representing diverse and underrepresented geographic and racial communities throughout the state. We also had over 40 additional community-based justice workers as strategic plan advisors who participated in the summit in an all-day strategic planning retreat and joined several post-summit action planning meetings to further refine this the goals for the plan. And we had, as you've heard throughout this series, data collection and analysis over the past few years. And can you go to the first slide again? Yeah. So this is the overall process. It was an 18-month project that took place from September 24 to Jan 26. And each phase of the project was designed to build on the previous one, to build the strategic plan as we went, and a more cohesive statewide coalition of community-based birth workers and stakeholders along the way. And the planning process focused on building meaningful consensus around key decisions at each phase before we moved on. As we said, there were 3 phases throughout this series. You've heard all the research that was done and the results from that, the summit, and then the strategic planning afterward. And we're now in the spring of 2026, and we'll move on to implementation after this. Next slide, please. This is a slide from the summit. It was in September, and it was the first Birth Justice Summit in Illinois. It drew people from across the state. It was a joyful and productive time. And as I said, the second day was saved for all-day strategic planning with community-based workers. And from this summit, the group identified over 20 goals for the plan, and during the post-summit meetings, these were narrowed down to about 11 goals, which you'll see in the plan. Go ahead, next slide, please. This is the mission, elevating community-based birth justice in Illinois. And by elevate, we mean to shine a light on and integrate community-based birth work into the larger healthcare system with the dignity that our professions merit and respect for the people who use community-based care and services. Our vision statement: everyone in Illinois has access to the high-quality holistic care they need to have safe, positive perinatal and reproductive experiences with the support and setting of their choice. And those providing care can access the training and resources necessary to thrive, strengthened by public and institutional policies that facilitate their success and sustainability. So the first paragraph is really geared toward, or the first sentence toward people receiving care, and the second is geared toward the workforces that deliver that care. Next slide, please. So all of this is in the plan, and you'll see it on the website too, but our work is justice centered. We place birth justice within the broader human rights framework. Specifically in Illinois, this work aligns with the Illinois Reproductive Health Act, which protects the fundamental right of individuals to make their own reproductive health care decisions, including conception, abortion, and perinatal care. Collaboration and coordination has been discussed a lot in this today. We are stronger together, working in partnership. Compassion. We know that we cannot pour from an empty cup. So taking care of each other and the people we work for at the same time is paramount. And the goal is creating structures that foster sustainability and longevity, not stress and burnout. And then power with, as Star mentioned, as community-based providers, oftentimes our kids go to the same school as the people we serve. We shop at the same grocery stores, and we share lived experience, and we see our clients as equals. Next slide, please. So these are the 5 priorities identified within the plan, and Anna's going to go more into these through specific goals and activities and key results for each priority area. Anna, take it away.
Thank you so much, Nora. And as Nora said, this has really been a collaborative process that has brought in people from all across the state that have so much lived experience and knowledge and effective solutions for how to address these problems. So I'm going to go through the quote unquote meat of the plan next. And as we go through that, something as we were thinking, let me back up a second. The next layer of the plan are our goals, activities, and key results. So as Nora said, at the Birth Summit, we worked with all our strategic plan advisors to brainstorm a total of 29 goals across our priority areas, which we then refined down into 11 SMARTY goals. And those are the goals that you're going to see today. So each of our 5 priority areas has 2 or 3 goals associated with it, with interrupting racism and structural violence embedded across all 11 goals. So SMARTY goals are specific, measurable, action-oriented, results-focused, timed, tracked, inclusive, and equitable. And our activities describe the different processes, structures, and resources that we will use to advance each goal. And key results describe how we will either track our progress or how we will know once we've accomplished our goal. So for program planners, we're talking about process and outcome measures. In thinking about how to communicate all of these goals, activities, and key results, which it's 11 goals, over 50 activities, and over 60 key results, we decided that putting the full text of each of these components on the screen and me reading them all through is not the best use of time or attention for folks on how to convey what this plan actually hopes to accomplish. So instead of reading through each of these components, I'm going to provide a quick reminder of the barrier or need that the goal seeks to address, followed by a basic summary of each goal and some of the main activities and key results for each. If you're a strategic planning nerd like me or just want some more detail or clarity on what we will be working on, you can take a look at the full plan on our website. Within our workforce priority, the first challenge we are trying to address is that the workforce isn't organized and there isn't a clear space to go for training and resource needs. So, we will be creating a birth justice workforce collaborative that supports birth workers' economic, professional, and organizing power to help encourage their professional growth and sustainability. And that'll look like creating communities of practice and learning collaboratives, publishing newsletters and resource guides, promoting ongoing training opportunities, and providing support for those navigating the certification and reimbursement process. The next challenge is that we simply don't have enough workers to meet the demand, especially in healthcare deserts. So we will be supporting the recruitment, training, and certification of at least 300 people from BIPOC and rural communities for high demand roles in the community-based birth justice workforce. And this will look like conducting a survey of training needs and priority areas, creating a database of training opportunities, launching an outreach and recruitment campaign, and centralizing job postings on a job board. The final challenge we are navigating is that health and hospital systems and community workers don't always know how to collaborate effectively or play nicely in the sandbox, frankly. So we will be building and disseminating a training that promotes that interprofessional collaboration and culturally responsive, trauma-informed, and holistic care in health and hospital settings. And this will look like creating sample protocols, incorporating the training into health system trainings, and providing opportunities for community birth workers and health system workers to practice and evaluate their competencies together. Within our infrastructure priority, the first challenge we are hoping to address builds on that last goal, which focuses on the collaboration across community-based and health system workers. This challenge is focused on the fact that health and hospital systems don't really know about how or understand how to partner effectively with community-based options and workers from an administrative and procedural perspective. So we will be creating an integration playbook to better understand and support the integration of community birth work into Illinois' health systems. And this will look like gathering stakeholder input, disseminating the playbook, working with hospitals to establish and practice transfer protocols, and evaluating and improving upon our progress. The next challenge is that we simply don't have enough birth centers or the staff or the funding to support them. So we will be working with the Birth Center Task Force on a plan to expand and sustain birth centers in Illinois. And this will look like identifying potential sites for new birth centers in perinatal health deserts, providing financial and technical support for opening new centers, and focusing specifically on growing the workforce of certified nurse midwives and certified professional midwives that we need to staff them. The third challenge we hope to address is that policymakers lack awareness around birth justice and community-based resources and how to support them, due at least in part to the lack of representation of community birth workers in legislative spaces. So we will be equipping stakeholders with the guidance and information they need to advocate for birth justice resources and policies that support them, and make sure that they get a seat at the planning table. This will look like creating a who's who directory of relevant players and policy briefs and fact sheets, creating a marketing campaign, releasing advocacy guidance to stakeholders, and ensuring that there are community-based birth workers present on relevant state boards and work groups. For the People's Experience priority area, the first challenge we hope to address is the fact that many community members don't even know that community-based birth options exist and how they can help with their perinatal experience. To address this, we will be launching a culturally tailored public education campaign about community-based birth options, which will include generating marketing materials for a far-reaching outreach campaign that will target community events, conferences, social media, and other platforms. And I saw in the chat someone posted about a billboard, and who knows, if we get the funding for it, maybe. The second challenge we are addressing is that people are not getting connected to the right workers and resources because it's hard for them to find the right support for their unique needs and identities. So we will be building a birth justice resource and referral hub that includes a provider directory, resources for other social determinant of health needs, connections to support groups, and educational materials. We'll do this by identifying all of the relevant resources, creating or hopefully partnering with an existing resource hub or app, and creating and facilitating new support groups where there are gaps. The final challenge in patient experience that we hope to address is the fact that we do not currently have a way to assess patient experience with their birth or hold health systems accountable to ensuring that birthing people have a safe and positive perinatal experience. In response to this, we will be establishing systems to regularly collect, analyze, and act on the experiences of birthing people to improve care quality, cultural responsiveness, and equity. And we'll do this by building relationships with relevant stakeholders, including organizations that currently monitor quality and health outcomes in health systems, evaluating the existing quality assessment tools, creating recommendations for metrics that fill in the gaps left by those assessments. Our final priority area of funding has just two goals, but they are both critical to sustaining this work. The first challenge we are addressing is the fact that, as we've discussed in depth, reimbursement rates and wages are currently insufficient to support living wages and financial sustainability of community birth options, and they don't cover workers' full scope of labor. To address this, we will build an advocacy plan and relevant materials to promote equitable and sustainable reimbursement rates and criteria. We will advance this work by identifying policy change priorities, working with legislative and regulatory partners to identify how best to actualize on these changes, and mobilizing on an advocacy strategy that includes developing feasibility studies and other materials to support. We also plan to engage with private insurance providers, providing recommendations to help make their coverage of community birth options more equitable as well. Finally, we will identify and support the implementation of other policies that have recently passed but haven't been implemented effectively, such as the policy that requires hospitals to allow Medicaid patients to have doula support. The final challenge we hope to address is the fact that many community organizations struggle to procure funding, and part of that is because funders lack guidance and accountability on how to equitably allocate resources to birth justice organizations. In response, we'll be generating guidance and systems for private, corporate, and public funders to better support the needs of community-based birth justice organizations. And this will look like drafting and providing recommendations for funders, collaborating with governmental partners on recommendations for more inclusive granting of public dollars, identifying and engaging new funders, creating a map of funding gaps, as well as a directory of funders in this space, and finally, exploring potential models to help financially sustain smaller organizations and entrepreneurs in this space, such as cooperatives. And that's the whole plan. We hope that you saw something in there that resonates with your experience, complements your existing work, or inspires you to want to get involved. And we will certainly need your help. This will be an all hands and resources on deck situation to make this plan a reality. And what comes next is that over the next few weeks and months, we will be convening working groups of community-based birth workers, advocates, and other partners to generate an implementation plan that will include setting timelines and measures, generating and allocating budgets, identifying who is responsible for what activities and where we can partner with existing efforts, and other elements. We will also be reconvening our coordinating committee to provide overall guidance and accountability of this plan to our mission, vision, and values. And we are actively recruiting for new members of our coordinating committee. So if you know of anybody who is a community birth worker who fits one or more of these care categories and are interested in supporting the implementation of this plan, please reach out and let us know. Nora, please drop your email in the chat so folks know who to contact. So we're particularly looking for Latina workers who serve immigrant or migrant communities, home visitors, folks that work in reproductive or abortion care, and folks representing communities outside of Chicago. And finally, we will continue to collaborate with other relevant strategic planning efforts, including the Illinois Birth Equity Blueprint, to ensure alignment and reduce duplication. So again, if any of these activities are of interest to you, or you just want to stay tuned on our progress, please fill out our involvement form and we will follow up accordingly. And for those funders on the call, I know I've seen some of you in our participants list. There's a special box for you all to check on there as well. Again, this was just a high-level overview of the plan, but you can view the full detailed plan along with the complete Smarty Goals, activities, and key results on our website, which I will show you briefly. We've got a few minutes. Second off. All right, our beautiful website is here, and you can, of course, click to download the PDF report, or you can scroll through and view all the different elements of our plans, our priority areas, and our goals, activities, and key results. And you can view the full text of the Smarty goals. If you click on these tabs, the full list of activities and key results will pop up. So for those of you who want to dig deeper into the elements of the plan or want to explore and figure out where you best align, there's plenty of ways to do that on this website. While I have this open, I also want to flag a couple other pages on here. For those of you who want to follow up or learn more about the research that was featured in our sessions, you can go to our research tab where you can read all the different reports and view more information about that research. If you go to our events tab, you'll be able to view recordings of all of our sessions and read the bios of all of our panelists. And I do want to highlight our reproductive justice and birth justice history page, which is really just a beautiful page that talks about the history of reproductive and birth justice in Chicago. So there's lots to learn here about timelines, about when things open, so that you can put your organization in context with everybody else. So I highly encourage everybody to spend a few minutes going through this site, exploring it, and finding what resonates with your experience.
Yeah, can I say one word about that, Anna?
You can say multiple words about it.
Yeah, that is also the history in Illinois. It starts very broad, globally, then it goes to the US, then to Illinois, then to Chicago. And there is a form there that you can click on to suggest edits or additions. So this is a living history, and please add your knowledge as you will. Thanks.
Thanks so much, Nora. And we actually have some time for a Q&A. So if you have any questions, please feel free to post them in the Q&A box in the chat. And we will go ahead and respond to them. We don't have much going on in there, so I'm sure, unless we just did a brilliant job explaining everything, which I'll take that feather and put it in our caps. I'm sure there are questions, so feel free to bring them up. They can be questions about the plan. They can be questions for our panelists. We do have one question here. Was the new-ish initiative at UChicago where CNMs can be a person's primary OB provider part of this? If so, are other similar programs being suggested or exist at other hospitals? I don't believe that particular initiative was a part of our planning process, but I think that is a really great example of an integration of community-based and health system resources that we would love to explore more and hopefully replicate in other spaces. Does anybody else want to comment on that one?
I'm not familiar with it, no.
So I know I saw a couple of our UChicago partners on the list of participants. So we'll follow up with you guys. But if there's someone specific that you think we should talk to, please let us know. We would love to connect. I do see a question in the chat. Are you taking certified doulas in St. Louis, Missouri by chance? I'm going to ask that question to Chastity, if you're able to chime in.
I guess I don't understand. What do you mean? Are we taking doulas in St. Louis?
I guess, are they allowed to practice in Illinois, maybe?
Yes, definitely. Definitely allowed to practice in Illinois. I'm going to put my email in the chat. So whoever asked that question, just email me and we can talk, and any information you need, I can give that to you.
Thanks so much. Any other questions? Feel free to put them in the chat or in the Q&A.
I also wanted to mention the doula lab in St. Clair, in the Missouri area, but on the Illinois side. They're a great resource down there.
Thanks so much. All right, well, I'm surprised for such an opinionated group. There's so few questions. Question from Lon: what is the time frame for the implementation plan? So this is a 2026 to 2029 strategic plan. So there's a lot to do here. We're hoping to take probably the rest of Q1 and Q2 to do some planning for the implementation, and to start mobilizing on implementation in the fall. So we'll be doing fall 2026 through 2029 to implement the plan, and then we will no doubt need to revisit it and figure out how far we've come and what we need to do to continue to advance this work, because I can't imagine our work will be done after 3 years.
Also, with the possible summit again happening in Q1 of 27 as well.
Yes, we got such great feedback about our first summit, and we want to continue that tradition. So please keep your eyes out for more information on our next summit next year.
And Anna, can you talk a little more about the next 2 quarters and how teams are going to be formed and things like that, so people know?
Absolutely. So if you're filling out the involvement form on our website, there's a box to check if you're interested in supporting the implementation of any goals or participating in any of our learning collaboratives or communities of practice. And for folks that have indicated that interest, and we'll also, of course, reach out to all of our original strategic planning advisors as well. We'll be sending out a more detailed interest form about which specific goals and activities you are interested in supporting. And then we'll be convening additional work groups to figure out the details of what we need to do to operationalize that plan. So we'll be in touch about what that looks like for those that indicate interest. And we're also very much looking for folks that if you saw something on here that you're like, oh, I'm already working on something like this, or this is really similar to something that I saw here, we want to know about that too. We don't want to duplicate any efforts. We want to elevate and leverage our existing resources as much as possible and reduce duplication wherever we can.
Yeah, and to be clear, I just wanted to say, there's 11 goals that we hope to really make us a strong dent in the next 3 years. And we cannot do it alone, the people on the screen or even on this call. So we're looking for leaders, people who would like to lead in areas. We're looking for people who just want to participate, might not have as much time, but have enough time they can set aside to work on a team. So yeah, please consider this group work and jump right in.
I do see a question in the chat from Jasmine Jones regarding the CPM training happening in Illinois. That's still slated to take place at Kennedy King, with the first cohort slated to start fall of 2026 of this year. And we can't confirm now, but the first cohort will be 20 people, and looks like we may have tuition completely paid for the first historic cohort, just FYI, in addition to also being able to provide stipends, insurance for clinical sites, et cetera. So if you do have a clinical site, you're a birth center, home birth practice, we still need more clinical sites. That's one of our biggest barriers in regards to not having a bigger cohort start first. But just kind of wanted to throw that on the radar. It looks like our first cohort will be able to attend full tuition paid. Yeah.
Thanks, Star. It is so thrilling that that's happening. Question from Lisa: are the citations from the presentation on the outcomes listed in the strategic plan? Yes, they absolutely are. If you download the full strategic plan from the website and scroll down, You'll be able to see it's all an AMA citation, so you'll be able to see all of those citations. It's also, we'll be sending the slides out as well, and the citations are listed at the end of the PowerPoint presentation. Lon, can you add where you're hoping the resources will come for the implementation plan? Great question. We are actively sourcing resources to support the implementation of the plan. So we know that this is going to be a heavy lift. We're already engaged with a number of funders. If you are a funder on this call and are not engaged with us already, we would love to talk to you and share more about our work and how you might be able to support activating this plan. We're also interested in exploring other funding models. We know that certain elements of this plan, like opening a new birth center, is not gonna, a $50,000 grant ain't gonna cut it. So we're gonna need to get creative and resourceful in how we are funding these projects. And all of that will be discussed during our implementation planning process.
Yeah, and real talk on the funding for the plan. I mean, one of the things we'll be doing when we form groups and teams and things like that, we'll be identifying funders, writing proposals, again, working as in groups. But as Anna said, there's a lot of momentum from funders and also possibly from IDPH in the state with their blueprint for birth equity, where they're overlapping. There's so many groups and teams talking about integration and training more doulas and work with people who use substances. So this will be part of the work, our writing proposals. I just gotta say that.
Yeah. And another question here, as a community-based doula where options for birth are directed by funders and we are bound to the hospital, I'm hopeful that this work will open up options that our funders will see as paramount for our participants. And that's what we hope to do as well. That last goal that we talked about is really about helping to equip our funders to make more equitable giving and ensure that these smaller community-based organizations that, don't necessarily have the resources to hire a full-time grant writer or have a full-time Medicaid billing specialist, to make sure that those smaller organizations can still reap the benefits of the resources that are around. I did drop the link to the strategic plan in the chat. I do encourage you all to take a look. It's really beautiful and has all sorts of additional data and information in it. I am going to start to wrap us up here and send some big thank yous out. First and foremost, to all of our researchers for their research, for participating in this series and lending your knowledge and expertise, to our coordinating committee members who guided this work from beginning to end, our strategic plan advisors who generated the contents of this plan, all of the people who participated in the research as survey participants or focus group participants, our generous funders who support our work and who will be continuing to support our work. I also want to give a special shout out to Wild World Mama design team for the beautiful website and strategic plan that they put together. And you all for being here, for being a part of this work, for being a part of this movement. We couldn't do it without you. So thank you for being here. And you can view a full list of participants on our website. And I also want to add that on a personal note, it has been a real honor and joy to facilitate this process with so many inspiring and passionate and brilliant individuals. And thinking about the incredible impact that the work laid out in this plan can have on communities fills me with hope. And we certainly need as much of that as we can possibly find these days. So to all of the community birth workers who welcomed me into your lives over the past few months, thank you for trusting me to help you all navigate this process. And I hope you feel as proud of and inspired by the final product as I do. So again, you can get involved and learn more about our work and download this full strategic plan on our website, birthjusticeillinois.org. And we do hope that you stay in touch because we will need all of us working together to bring this plan to life. And before we close, I want to hand the mic back over to Star for a moment to share some concluding thoughts.
Thank you so much, Anna. Thank you to everybody on the panel, everybody that's participated and supported this project, from the coordinating committee, anybody that's led any gathering of data that's helped to contribute to the findings that we had today, and also everybody that's on this call that's working in our different areas to try to improve the reality for so many people that just want to have a safe place to give birth in this state and be able to really live in peace and to have sovereignty over their bodies. So thank you so much. As I close, I want us to leave not just with urgency, because this is an urgent matter, but also with hope. Because what we are building together is powerful. We are witnessing a moment where community wisdom is rising to the surface, where midwives, doulas, advocates, and policymakers and families are sitting at the same table, not as adversaries, but as partners. That alone is progress, and we really need to take a moment to just think about that. The Illinois Community-Based Birth Justice State Strategic Plan is more than just a framework. It is proof that when community leads, solutions follow. I think Megazin has said it very well. The answer, the solution has always been in the room. It's us needing the space and the funding and the resources to be able to implement it. And now that we have a seat at the table, I think we are definitely well on our way. It's proof that equity is not an abstract value. It is something we can design, fund, and implement together. I'm encouraged because the momentum is real. The leadership here is real. Just look at this panel. Look at the people who spoke this morning, who are leading in ways of trying to implement change. Look at everybody that's on this call and the work that you're doing individually to help lead us in the right direction. The vision is clear, and the commitment in this room and across the state is strong. We do not have to imagine a better system. We are already building it. A system where Black mothers are trusted, where community-based providers are resourced, where birth is supported with dignity, culture, and care. The work ahead will require courage and collaboration. But we are not starting from scratch. We are standing on generations of resilience, innovation, and love. This is our opportunity to align our power with our values right now in this moment in time, right now in history. As I mentioned before, the fact that we are all in our seats at this time in history in place right now is not a coincidence. We all have a divine assignment to move forward with. And I believe that we're ready. Together, we are not just changing policy, we're shaping the future of birth in Illinois that will not only affect our children, but our children's children and generations to come. Let's move forward together in solidarity, with clarity and partnership, and mostly also with hope and love. Thank you so much.
Thank you, Star. I have nothing else to add. Thank you, everybody, for being here. We hope to see you again soon. Have a wonderful day.